to health, safety, and welfare, and COVID, as well as moving on to some different aspects of bargaining and other legal things that will depend on some of our counsel for. So the first part we will start with is our health, wellness, and safety, which we have Dr. Kalala, who is our EMS medical advisor for the Professional Firefighters of Wisconsin, Dr. Weston, who oversees a huge number of fire-based EMS providers in Milwaukee County. And we have from the IAFF, Rob McClintock and John Nemec. And I've kind of sent them some ideas and topics to discuss, but what's most important is that you get your questions answered. So we do have some material that we'll go over, and we'll just go in the normal way that we always do, starting with Dr. Kalala as state medical director. He's always able to give us kind of a bird's eye view of where things are at with the state. Last time we were together, it was more a discussion about if we're going to get vaccinated. Now it's a matter of, as many of us have already had our second vaccination or are moving on to our second vaccination, the side effects that we've had, the what can be expected after vaccination number 2, as far as pumping the brakes on exposure control, and things like that. Also, perhaps what role EMS may play in the grand scheme of things in the state as we get on to vaccination. I think we all can appreciate that the words vaccine and vaccination are two very different things. We may have a ton of vaccine, it's getting it in people's arms that might be the problem, and where our members, even perhaps our retired members, may fall in that category based off of the fact that we are in some declared emergency statuses here. And just because perhaps you've been retired for a year and let your license go doesn't mean that you aren't just as competent in putting an intramuscular injection into somebody as you were a year prior. So just all those kinds of things, bird's eye view from the state. Then, I'll just have Dr. Weston kick in anything he has specific for fire-based EMS providers in the largest system in the state. And then we'd love to hear from John and Rob, and DVP Thornburg can hop in at any time related to what the IAFF is seeing through their partners. So I'll kick it off to you, Dr. Kalala.
Great, thanks. Good morning, Jerry. Good morning, everyone. It's nice to see you all again. Jerry, is it okay if I share my screen, please?
Please do.
All right. I'm disabled, so if you're able to give me permission to do that.
Oh, do I have to co-host you?
Yes, sir.
Oh, God.
The real challenge.
There we go. There we go.
Almost. Let's see here.
There we go.
Perfect. All right. Give me just 1 second. All right. So you should see a PowerPoint up in front of you. Let me just get, it's a quick one. It's just 3 or 4 slides, but I thought it would just be a nice way to frame this. So just Jerry, thumbs up if you see my slides. Perfect. Excellent. All right. So I'll talk a little bit about a couple topics that I think are just important for your awareness, and I can answer the question about role of EMS as well. So certainly there is good news, right? Through a lot of efforts, EMS and fire-based EMS have been squarely centered as a high tier priority. So I think it's safe to say that most people who have wanted vaccine that fit into the emergency service sort of category have had an opportunity to get vaccine, at least certainly in this metro area, but in most parts of the state as well. So I think that the question moving forward for your organization is, how do you continue to nudge people who are maybe uncertain or have other views about that. So I think that's something that you can sort of think about as a strategy. But good news is that a lot of effort has gone into making sure that you have access to vaccine. You're probably following the news. Johnson & Johnson will soon be approved under emergency use authorization, probably in the next week, I believe, is when they meet again. So this will definitely be a game changer, mostly because, as you know, there's not a whole lot of storage requirements around it, and it's a single dose. So I think this is really going to be an important part of Biden's plan to vaccinate over 1 million people a day. So so more to come on that. Stay tuned. And for those of us who have had vaccine, we've likely received mostly Pfizer, or maybe some of you have received Moderna. And also the good news about that is evidence suggests it's pretty effective, highly effective, I should say, against some of the variant strains that you're hearing about, in particular B.1.1.7. So that's some of the good news. The CDC, I believe about a week ago, put out some interim guidelines talking about the topic of whether it's necessary to quarantine after you've had exposure if you've been vaccinated. So the conditions around this basically suggest if you've been fully vaccinated, meaning you've had, at this point, you've had 2 doses of vaccine, and there have been at least 2 weeks of time after your second dose. So that's one criteria. 2 is that it's been within 3 months of receiving your vaccine series. And 3rd is that you've remained asymptomatic with the current COVID exposure that you may be encountering. So, these are interim guidelines. It really is up to agencies to decide whether or not to implement it or not. And what I'm sort of hearing just nationally is that some agencies are doing this, and some are continuing with the pre-vaccination quarantine suggestions. So, I think that there was an article published in New England Journal that suggested that those that receive vaccine have good protection against the infectious parts of the virus. I think more to come on this, but I just wanted to sort of put this into your lens. And this also kind of fits into the discussion about, now that we've had vaccinations, do we have to wear masks in our station? And this is a bit of a tricky topic because, if agencies were to move in this direction, it really hinges around the understanding that everybody in that station is vaccinated and has had the full series with the 2 weeks following. So I'm not advocating necessarily that we do or do not. I'm just saying that this is a conversation that's occurring now. Certainly if with your family pod as an example, there is certainly evidence to suggest that you can be able to meet without, or not just your family, but with other groups, you're able to meet as long as you've all been vaccinated. So I think this is going to be a bit of a contentious area, but certainly it's something to start thinking about in terms of policy. This also morphs into the idea of what happens after you've been vaccinated and you were to experience COVID symptoms. So I think, and part of what Jerry teed up is, what do you expect after you get your vaccinations? So certainly within a few days after your vaccination, either the first or second series, you'll have normal sort of immune system response. So things like low-grade fever and muscle aches and headaches and localized, arm soreness, that kind of thing. Those are all normal and customary and exactly what you would expect to happen. Anecdotally, it sounds like folks that may have had COVID in the past seem to have a little bit more of a response after the second vaccine. But again, that's anecdotal from what I'm just reading in some of the publications. But so all of those things are normal and customary. The question though is, what happens if you have other symptoms and how do you tell? So really it will be important to understand, if you have typical side effects from vaccine within a short period of time after the vaccine, those are customary, and there's not necessarily a need to keep people from working unless they have unusual symptoms like a loss of taste or smell, something that you would not expect after a vaccine. And then there's a role for testing in those unusual circumstances. But by and large, if you have a vaccine, your immune system should do its job. And shortly after, within a couple days, and anything outside of that, you should think about, have you been exposed either to something else, to influenza, or perhaps even reinfection, which I'll talk about in a few minutes. It's interesting. There are a number of employer incentives around vaccination. And I know that right now, most employers do not require this as a mandatory condition to employment. But it's interesting, what I'm seeing is that in some healthcare agencies, they're incentivizing with a bonus. So that's a pretty unusual and interesting way to incentivize. But two is they're also incentivizing folks that if they have illness, COVID illness, after vaccines offered, instead of having sort of kind of protected time where they would not sort of dock your sick time, they're requiring employees to use their own sick time if they got exposed and failed to take the offer of a vaccine. So I just want to put that out there. I know those are some of the ways in which employers are trying to incentivize. And, as you think about negotiations with your work, maybe there are ways that you can, help to incentivize and protect your workforce. A couple other things, just so if you've been watching the trends, we are having a little bit of a decline in our infection rates. And so there certainly is great opportunity to celebrate this. And the questions really are around, why is this happening? There's been some discussion, could this be a consequence of vaccination? Pretty unlikely. Really, about less than 2% of the country had been vaccinated, nationally. So most experts don't feel like this is the most likely reason. Certainly, it helps, but it's not probably a significant reason. There is discussion about seasonality. So at certain times in the year, does the season affect the virus? Certainly, I think probably the thing that we need to understand and probably don't want to hear is just all these public health measures at the end of the day are really the most important thing that we can do until we hit that magic 70+% community immunity. So, I think those are definitely reasons why this is happening. But the other piece of this too is there might simply be testing fatigue, where people are just not getting as much testing. And I think certainly the state and national numbers look that way. Dr. Weston might be able to speak about kind of the testing in Milwaukee County as an example, but I suspect it's following the same kinds of trends. So those are some good reasons why infection rates are dropping, and maybe a not so good reason. But I think it's really important to understand that we are so not out of the woods right now. We are still measuring at least 91,000 new cases of coronavirus in the United States every day. And the modeling suggests that by June 1st, we'll have at least 150,000 more deaths. And actually, that number would be about 100,000 deaths higher in the absence of vaccine. So, I think this is still grim and something we need to understand. I mentioned before about some of the variants, and while the 117 variant seems to be receptive to Pfizer and Moderna, there are some concerns emerging about the B1351 and the effectiveness of our current vaccine strategy. So I think we're going to need to pay attention to this. This is one of the reasons that I'm still cautious to not drop mask wearing, in my pod or my circle of friends, just because, especially like you, many of my friends are emergency medicine physicians and EMS providers, and we're just inherently more exposed to the public. So I think that's one of the things I take a little bit of caution with. And then, finally, I think all of us get fatigued with public health measures, right? I think this is a reason why we're not out of the woods. As you're seeing, a lot of, there's been a lot of discussions on states around the country to, reduce or eliminate their mask wearing or any of the social distancing things. And we're seeing some of that here, of course, legislatively in Wisconsin. So I think these are some of the things that just predict that we've had 3 cycles of COVID, 3 surges of COVID so far. And, it's likely, unless we really, were to kind of keep on doing what we're doing, that we're going to, have another cycle at some point in the near future. This is just the inevitable trajectory of these kinds of infections. So with that, I think actually one other thing, Jerry asked just if I spoke a little bit about the role of EMS. So certainly, at the state level, we have had, there are critical opportunities for EMS to be involved in the vaccination scheme, whether they are part of a department program, whether they're coupled with public health. Some parts of the country are looking at using paramedics and EMS providers to deliver vaccine in people's homes, maybe for the vulnerable who can't get out. So there are lots of opportunities. Certainly from the state level, we've put a lot of effort into ensuring that the practice of testing and vaccination are within the scope of practice as optional skills. So you're empowered to do that, with your medical director oversight. I think the only caution I would really have, and something for you to consider, is, does this become yet another sort of task or burden to the EMS system, who already is stretched pretty thin, who's having, a tremendous impact as a result of the vaccine? And, could this be an area where you could negotiate if that's, a direction you want to head in? Certainly, I think all hands on deck would be important to help vaccinate. But, all of these come with opportunity costs that I think, just something for you to think about. So I'll stop the slideshow now and give the slide back to Jerry. And if you have questions, I'm happy to take them.
Okay, yeah, we're going to be using the raise hand feature. So under my screen looks different just because I'm the host, but if you go into participants, I believe there's an opportunity to raise your hand with any questions you may have. So Doc, just to clarify, when say you've had your shots, you've gone your 2 weeks, and now you end up having like cough or cold symptoms, and the employer wants you to be tested for COVID, would that still be appropriate, or would it be likely that it's some other bug you picked up?
Well, so that would be totally appropriate because, again, the conditions around this from the CDC is that you remain asymptomatic while you've been exposed. So if you have new symptoms like a cough is something that you would not expect after as a vaccine side effect. So if you had cough, then I think, at this point, cough from COVID and cough from anything else, it's indistinguishable unless you're tested. So it's totally reasonable for your own sake and for public health and your firehouses to be tested to make sure nobody else gets sick.
Okay, and is there anything in the scope of practice in the state of Wisconsin that would prohibit an EMS practitioner from at least EMT level or higher from taking part in any of the vaccine clinics?
No, the only limitation, so actually all of our providers from EMR through critical care are able to vaccinate. The barrier for this vaccine is that it is a intramuscular injection. So because it's intramuscular, EMT and above. But as an example, if this was an intranasal spray for something, that could even be an EMR skill. So really for this, the only barrier is that it is an intramuscular dose and it is an optional skill. So what that means in the state of Wisconsin is that it requires local medical oversight to be able to approve it for local use. But from the state side, we say use it if you want it.
And I understand if paramedics who are retired decided to get involved through something like Weaver, they would only be able to volunteer their time, right? You can't accept payment for that.
My understanding of Weaver is that's exactly what that is for. Yeah.
Okay. So if anybody is trying to utilize retired folks, and this is probably where Dr. Weston can jump in if he would be so kind, is to what the role might be. One, in the firehouse, like what are you hearing chiefs question you about as far as when and if these masks would be doubled up like the CDC seems to be hinting at, or go away if everybody is vaccinated, or and also the piece about being involved in clinics. You know, we get into the Dane County, Milwaukee County bubble where everything just seems to happen very much the way it's supposed to, and forget all those other counties where it's not going as great.
Sure. Yeah. Good morning, everyone. I would say as far as the masking, it really depends on what we learn about the vaccine. So the one big unknown about the vaccine is how we know it prevents symptoms and certainly severe symptoms in the case of all the vaccines that are being studied. But what's unclear is whether it prevents infection in the first place and therefore transmission. So could you have an asymptomatic infection? Your body's able to fight it so that you don't get sick, but could you still pass it to other people? The new CDC quarantine guidelines that came out last week began to speak to the idea that transmission is much less likely, and there's studies that are just starting to come out that are showing that your viral load when you have the vaccine is much lower than other people. And so if you have a lower viral load, you're less likely to spread it to others. So I think in the coming weeks and certainly months, we're going to see more and more evidence. I hope, and I think that that's going to be the case, that it does prevent transmission as well as symptomatic infection. Once that becomes really ironed out and understood, if that is the case, that it prevents transmission, that's when we can start pulling back potentially on those who are vaccinated wearing masks, those who are vaccinated getting together in groups, those who are vaccinated getting back to a life more as normal. So I think the research is really the gap there, understanding that transmission piece, but I hope that'll start to be filled in. And I think, the new CDC guidelines, so for those who aren't familiar, basically if you're vaccinated and you're 3 weeks out or 2 weeks out from your vaccine, you no longer have to quarantine if you have a close contact, provided that you're asymptomatic. Now, they say that's only for 3 months after the vaccine, and that's not because there's been a lot of misunderstanding and misinformation here. It's not because that at 3 months after the vaccine, it stops working. It's because we don't have very many people who are 3 months out from the vaccine. It's really people that they did research on. And so that's sort of the beginning timeline. I think the presumption, and certainly my guess is that a month or two from now, they're going to say, okay, I think we can go out to 5 months. I think we can go out to 6 months, whatever it is. So I think that timeline will get extended, as opposed to looking at these new CDC guidelines as, what's the point of getting the vaccine? It's only going to help me for 3 months. That's not really what the intent of the guidelines are, or the thinking behind it. So to double masking, masking is all about layers and effective layers. We know that, N95s are about the most effective layer you can have. Surgical masks are not quite as good, but pretty good. Cloth masks are a little bit better. Single layer things like a gaiter start to become not terribly useful. And so it's really about the layers. So if you have an N95, if you have a KN95, there's not too much point in double masking. But if you have a single layer, like if you have a gaiter, you probably want some other layer along with that. So it's really about the layers more than it's about double masking per se. So if you have a multi-layer cloth mask, if you have a surgical mask underneath that, I'll tell you personally, if I go out, where I don't think I'm going to have a close contact, I'm seeing a neighbor out in the yard, I'll wear just a cloth mask. If I'm going to the grocery store, I'll wear a surgical mask and then put a cloth mask on top of it. So I kind of do it based on what I'm doing. And then the only time I do an N95 is if I'm, with an aerosol generating procedure in a patient in the emergency department, basically. So I kind of, modify my mask, and I think a lot of people do in the same sort of way. As far as the fire departments in Milwaukee County, we've seen great uptake of the vaccine across all of our departments, really, even ones that initially said they were going to have a lot of hesitancy and didn't really want to do it. I think once they saw other people starting to get it, they wanted to jump on too. So we've seen really good uptake, both private and public, or our municipal health EMS has had really good uptake, very low side effects among our EMS providers. Just, I think, a handful of people that had to take the next day off for the kind of flu-like symptoms that you sometimes get for a day afterwards. So overall, our issue in Wisconsin, I think right now, is certainly supply. We just don't have enough vaccine supply on a national level. We haven't really gotten to the point where the challenge is infrastructure. We have plenty of people who want to give vaccine. We just don't have the supply to give it. And then I think a future challenge is going to be hesitancy. I don't think we've vaccinated all the eager people yet. And so we haven't really hit the point of where not many people want it because of hesitancy, but certainly that'll come in the future as well. I think especially in people of color and underserved populations where we know there's higher hesitancy, as well as just lower access to healthcare in general. And then I think the last thing I'd say is we're seeing really nice low case numbers basically throughout Wisconsin, low hospitalizations, low percent positivity, which is great. The cycle we're seeing, and we've seen over the last 10 months, is that when things get low like that, people start to let up their guard, and institutions start to let up their guard and pull back on indoor dining and whatever else. And then inevitably we see it start to tick back up. Obviously vaccines will help with that. Right now, about 10% of Wisconsin has received at least one dose of vaccine, which will certainly help to blunt an effort or a spike to come. But we also see that variant, that UK variant in particular, that's 70% more contagious, up to 35% more deadly. So I think we're in a little bit of a fight against time where a spike presumably is coming, because that's what's happened. Every time the numbers get low, a spike comes. And we can fight that spike with basic masking and physical distancing, and certainly with the vaccine, but it's going to be a lot harder this time because of the new variant. So we'll see what comes in the next couple months, but I think certainly continuing masking, continuing physical distancing until we see what happens with the spike, and until we have a better understanding of the vaccine is going to be really important.
And just one follow-up, Doc. If we say we have an engine house and everybody but one member has gotten the vaccine, they've done their 2 shots, they've waited their 2 weeks, everybody's asymptomatic, but we have that one member that is abstaining from getting the vaccine. What's the recommendation for that firehouse then?
Specific to quarantine, you mean?
Well, as far as like what would all of those members that had the vaccine, are they then kind of put back into that scenario where they're forced to follow all of the infection control guidelines because one member has refused to get the vaccine?
So I'll give you my answer, and Dr. Colella certainly can give his as well. So my answer would be, maybe 2 questions. So one is, should everybody continue to do personal precautions, masking, physical distancing, everything like that? So honestly, even in a firehouse where every single member is vaccinated, every single member has received both doses, they're all 2 weeks out. For now, unfortunately, everybody should continue to mask and physically distance. And the reason why is, maybe I'm in the firehouse and Jerry's in the firehouse. And I also live with my 80-year-old grandma, right? And Jerry lives with his, 3 kids who are 20 years old and like to go out to bars. So Jerry's kids go out to a bar and get infected and they're not vaccinated yet. They give it to Jerry, he has asymptomatic infection. Jerry gives it to me, I have asymptomatic infection. We're both fine because we're vaccinated. But then I bring it home to my 80-year-old grandma and give it to her. And so it's not, if you all lived in the firehouse and never left the firehouse and had no contact with anybody outside the firehouse, take off your masks and enjoy yourselves. But unfortunately, nobody lives in isolation. And so for now, until we understand that transmission piece, whether it's 1 person in the firehouse doesn't have the vaccine or 20 or 0, those personal precautions still have to stay in place. As far as quarantine, that is different. So the 20 people who've gotten the vaccine don't have to quarantine if they're out from their vaccine and they have close contact. The 1 person who didn't get the vaccine, they still have to go in quarantine.
And yeah, I would add also just as long as they remain asymptomatic, they don't have to quarantine as long as they're asymptomatic. And I agree. I think we just don't know enough yet. I know everybody wants to take that mask off. I just don't think that there's enough data to suggest that we can do it safely. And I think the other part about variants, we've had at least 2 documented cases of the B117 in Wisconsin, and these are from people who didn't travel and had no other exposure. So what that tells us is 2 things. One is it's much more common than we think, and I can tell you that our state, like many, has not had the infrastructure in place to do a lot of this genomic testing. So there might be a lot more variant than we're aware of. And the doubling time, at least from the UK data and other places, is every 10 days, we're seeing a doubling in variant. And I think, Fauci and others predict that we'll have predominant variant form in this country soon. And we just don't know enough yet. So I think, vaccine is critically important. But I can't underscore how important it is to continue with these mask things until we have just better understanding, unfortunately.
All right, thank you guys. Always appreciate it. Now I'd like to turn it over for any additional health and safety updates from our union and great supporters, John and Rob. Mr. Nemec, can we start with you?
Absolutely. Good morning, everybody. To both docs, very comprehensive, spot on, and we'll obviously add a few things. Before I turn this over to my great friend and colleague, Rob McClintock, I just want to say on behalf of our General President, our General Secretary Treasurer, thank you, Jerry, and also to DVP Thornburg. I want to say congratulations. Thank you for allowing Rob and myself to come out here this morning. To State President Mitchell. And I had echoed this last time on behalf of my friend and colleague, Rob. Jerry, hats off, unbelievable amount of work, education on getting the entire group of men and women together. And, you know, because it's not only about embracing and promoting, but it's about educate, educate, educate. So Jerry, hats off, great, great job. And then, you know, I also want to say very briefly that it's been a great, great time and a lot of great stuff with our IFF COVID-19 team, Rob McClintock, and also Raquel Siegel. So Rob, I'll turn this over to you, brother.
Thank you, John. Good morning, everybody. I truly appreciate joining this webinar, especially listening to your docs because they're so engaged. It's very welcome to hear their reports, and we appreciate that very much. Just from the IFF's viewpoint on the quarantine, the new quarantine guidance that's been released, we are a little bit hesitant to do anything with that for a couple of reasons. And the doc hit most of it being the fact that the science just isn't there yet. And that's the way our Hopkins doctors feel. And the second reason is because the J&J shot, the efficacy rate is only 66%. Most of our members right now are getting the Moderna and Pfizer, which is 95%, which is awesome. But we're not sure what the J&J results are going to be. So we're kind of hesitant just to move forward with that guidance just as of yet. We do recommend that you still go into quarantine with a high exposure. And in addition, you know, as far as the vaccine, not only do we strongly recommend it, also our guidance is we just recently released guidance to help you think of your safety while you're at a vaccination distribution site. The doctor hit a really good point, and one of our concerns too is that we want to make sure that we are reaching out, right? Social inequality is a real thing. We want to make sure that we are reaching out ways. We just can't have drive-throughs, vaccination sites, because some people don't have access to cars or travel or anything like that. So we have to set up programs where we might be a little bit more mobile, and we have that capability of doing that. And we support that 100%. We support our members getting out there and help vaccinate and help control this environment as much as we can. Additionally, we have not moved towards the use of double masking yet. We're a little hesitant on that as well because, well, quite honestly, it's hard enough to get our members to wear one mask. So I would prefer one mask over the angst we're going to get over wearing two masks right now. So that's our position on the mask and the vaccines. I would love to entertain any questions if you have any. In the meantime, I know John has a couple things that he would also like to cover. So back to you, John.
Thanks, Rob. Hey, Jerry, I just would like to add with what Rob was saying in with the docs. You know, we are not only educating, but most certainly embracing that folks continue with the big four pre, during, and post-vaccination. If you remember from our last webinar, the big four include mask or face covering, doing self-assessment while you're at the station, and even at home, if you want to go ahead and take your temperature at least once or twice a day. Frequent hand cleaning and apparatus around the station, also at home. And let's not forget social distancing. You know, some of the members think or feel that that's like an a la carte, that I get to choose which ones I want to use. And if we're really going to be efficacious, if we're going to minimize our exposures, especially around the firehouse, And even at home, these are some practices that all four need to be inclusive. While we continue looking at other things, other stuff as it relates to COVID-19, our attention right now is really on this vaccine. And on social media, and I would venture to say that most of the members who are on this webinar this morning are on social media. So you get to see, read, and perhaps even actually participate with, the goods, bads, and the uglies with respect to, the vaccine. We have got to continue educating our members. Look, we know that 7, 10, maybe as even high as about 15% of our members are just no way, no how going to entertain themselves or their family members to get the vaccine. And most likely these are the same members who don't get the flu vaccines and other vaccines that are out there. That having been said, I say this very respectfully that we have got to look at Wisconsin. Jerry, you need to look at, those, not so much the fence walkers, but the folks that are just really unsure. Do I get the vaccine? Do I not get the vaccine? Rob and I participated with another district's COVID-19 webinar. And the docs who were on at the time, right up front, did a very brief poll whether or not if you would get the vaccine. And I want to say, Rob, that when that initial poll that came out, it was about 35% of the folks who said, yeah, I would go ahead and get it. I would get, both vaccines. Once the doctors went through, did as far as Q&A and really hit home on the vaccination and how it impacts you, the members, the family, and the community, the webinar then did a post poll after the docs got on. And I'm going to say that went from about 30 to 35%, as high as 60 to 65%. So, Jerry, perhaps, with what the docs had just said, maybe doing a 15, 30 minute, webinar, again, just honing in and focusing in on dealing with the vaccine. And you may have already done that, brother, because you do unbelievable amounts of work that's out there. So, like Rob said, as it relates to our members who have gotten the vaccine, have had a high risk exposure, after consulting with our docs at Johns Hopkins, because the data and the science is just not there, just like cancer, there's some stuff out there, and I know I'm actually digressing here, but folks want to know how come we don't embrace or actually support cancer sniffing dogs, and as far as saunas after fire. One of the things the IFF takes a lot of pride in is dealing with those facts, dealing with the science, and just making sure that's all there before we make the recommendation. And, with respect to not putting folks in quarantine, science is just not there. The last thing that I will say, and of course we would like to have some Q&A, is while we don't always agree with the CDC, if you recall very, very early as this virus was rolling out there, and as a matter of fact, we're coming up on a year already with the first event that we know of out in Washington State, that the CDC had established a floor or a base with wearing N95s out in the field. And then after they found out, as far as supplies, you had a lot of the N95s that were actually expiring, or they were expired, that they then came out to say that it was okay to wear a surgical mask. Well, and there are some other examples that are out there. We are trying to get our members, along with the IFF, to reestablish that trust word with the CDC. And Rob, myself, and others from the IFF last week had a initial meeting with CDC, and we're looking at down the road, hopefully having a webinar that will hone in on the 3 areas, looking at vaccinations, looking at PPE, not only for our members who are going to be giving the vaccinations, but to ensure that the PPE and supply is out there while you're running the calls all day, every day. And as the vaccine has been and continues to be rolling out, what happened to that testing word? It seemed like that has really gotten suppressed. So those are like the three areas that we want CDC to focus in on. So we would say, Rob and I would say, stay tuned, that we would like to have an interactive webinar with CDC in the very near future. So Jerry, I'll turn it back to you, brother. And Rob and I are here for any questions.
Okay, I don't have any raised hands. I just had one question related to antibody testing related to the vaccine. Is that still not an option? I know we have the antibody capabilities related to if you actually had COVID, but anything related to vaccine antibodies?
No, not that I've seen, Jerry.
Okay. And then when they talk about those percentages, 95% effective, 96% effective, does that mean for everybody, or there's 4 people that this out of every 100 that this isn't going to work for? What do those percentages mean when they say, like J&J says, we're in the 60 percentiles or something to that effect?
If I understand the question, I think what it suggests is based on the volunteers that they had in the trial, that projects the population of people who would receive that vaccination being protected or not protected.
So for Pfizer or Moderna, we still have the potential of 4, 5, 6% of our folks that may have gotten both shots. But just like the hepatitis B vaccination may not have antibodies at some point when we can test for that.
I'm not sure I understand the question.
On that maybe. So,
Yeah.
If you have 100 people who were vaccinated, 5 to 6 of them, depending on Moderna or Pfizer, may still get infected. So it's not, so it's efficacy versus effectiveness, and it gets into a complex, long topic. But basically, you could think of it as out of 100 people, 4 of them may get infection over time. And I think one other thing to branch off this, if I can, is the Johnson & Johnson has been getting a lot of grief because it's only 66% effective. It's 80-some% effective in severe symptoms, which they defined much more conservatively than Pfizer or Moderna did. So their severe symptoms is positive test and any one symptom. So cough and a positive test, they considered a severe infection, which I don't think most of us would consider a severe infection, but they were pretty conservative with that. And Johnson & Johnson was 100% effective versus hospitalization and death. So the discussions on the vaccine, unfortunately, are getting way more complex, not just because of the strains, but also because they're researching a little bit different things. So, for example, if one vaccine says, well, we consider severe infection, you get hospitalized, and we protect 100% against that. And the other one says, well, we consider a severe infection as you have a persistent cough, and we can only do 80% against that. Well, you're not really comparing apples to apples. So it gets a lot more confusing. But in the end, it seems like Johnson & Johnson is still a pretty good vaccine. And to get back to your original question, when they tested thousands of people, 4 or 5 to 6% of them still got symptoms and tested positive. I don't know if that's a great answer, but
so it is. So I guess from a risk standpoint, and perhaps thinking that you could move away from all of the things that John had mentioned are not a la carte. You have, even if you've gotten your 2 shots and it's been 2 weeks, and at the end of the 2 weeks you seem perfectly fine, you still have a chance of 4 or 5% that shot will do nothing for you, or that it will that shot do something for you? Like, even if will it at least make you less sick or less likely to die, or is there a chance that 4 or 5 of us out of every 100 may get zero protection from that vaccine?
So nobody really knows that question. I think the presumption, the science would definitely point to you're still getting protection. And so the vaccine provides a lot of different protection. So it provides antibodies, which we can test for, but it also provides things we can't test for. So there's like this T cell immunity, so special cells that fight off infection too. We can't test for those. And so even, if you go out and test that's why they didn't check the vaccine by who has the antibody on the antibody tests. It's not a real accurate way because there's lots of different defenses our body has that this vaccine teaches our body to use. So it's beyond just antibodies. But the presumption would be, it's not like, so, there's 44 people on this call. So what's, 6% of that is, I don't know what, 2 people, something like that. So it's not that 2 people on this call, the vaccine didn't work, you don't have any immunity. It's 2 people on this call, your immune system may not have responded quite the same to the vaccine, and you may not have quite as much immunity. So, I'll just use you and me. If you and me, Jerry, are the 2 people that were unlucky enough on this call to not get the full immunity, we may still end up getting, we get exposed, we get a cough, we're laid out for a couple days. Probably we're certainly not going to die. Nobody in the trial died when they got, and this is tens of thousands of people. We'll see once it's millions of people, but in the tens of thousands of people, nobody died when they got infection, which certainly isn't how it works in the community. I'd have to double check. I don't think anybody got hospitalized when they got an infection. So the 2 of us may still get sick. We may even be laid up for a week and feel like we have the worst flu of our lives, but we're probably not going to get hospitalized. We're very likely not going to die, but we may not have quite as robust a response as everybody else on this call did, where they don't even know they had it because they're asymptomatic. Does that make sense?
It does.
I think the other part of this too is, so death isn't the only outcome of COVID, right? So it's all the other long hauler sort of symptoms and other risks that come with COVID that, we still might be that 6% still might be at risk for. But I'll tell you, and I think kind of what people are sensing is I'd rather sort of take the vaccine and, know that my chances of dying from it are essentially non-existent.
Okay. Rob, did you have something?
Yeah, I just want 2 things. I just wanted to clarify, I wasn't knocking the Johnson & Johnson vaccine. I was specifically speaking to the purpose of quarantining and maintaining quarantine, because even if it's 80 some or whatever, if you have a mild symptom, we don't know that transmission rate. And like the doc said before, I don't want to bring it home to my grandmother or, something like that. So that's why we're a little hesitant on moving that to the whole quarantine thing. Secondly, I just want to let you guys know the IFF had finally, we probably should have done this a real long time ago, but we finally developed what we call a COVID-19 policy guide, where we assembled all our resources from the website and kind of placing it into one document so that we can send that out to the affiliate leaders to share. And then if they want to, they can assist their administration and, to develop more stringent or less stringent policies based on the facts that we have from our website. So we just kind of assembled it all into one place. So it's easy to find, so you don't have to navigate through, 30 different links on the website. So we are putting that together. Hopefully that will be released in the next couple of weeks. It's in the editing process now. So we just wanted to make mention to that. And like I said, we also did release last week the vaccine distribution guide, which I think is going to be helpful. We've been on meetings at the national level, and your state's pretty progressive. Unfortunately, there's not many states like you. So EMTs, a lot of EMTs cannot give the IM injection. So at the national level, to help push this out, they're going to under the scope of practice, going to push out an emergency order to allow EMTs to do it, which will hopefully prompt the states either create waivers and training for EMTs to also assist in getting this vaccine out. The problem is we only have so many paramedics in the United States, so we're going to have to solicit not only our retirees, but we're also going to have to solicit probably our EMTs and maybe our EMRs. So keep up the good work, guys, and thank you so much.
Thank you very much. If I could just put, if the docs and everyone could just hold for